Abul will start. Abul?
Yes, sir. Yes, sir. Good evening, sir.
Yeah, good evening, sir. Respected National President, Dr. Jayalal, sir. Our guest speaker, Dr. Russell D'Souza. Our moderator, Dr. Abul Hassan. And our we have also invited guest, Mr. Subhash Gupta. He is there. And our delegates across India, and they are still joining. So today we are going to have the lecture based on the Dr. KK Memorial Lecture, which is dedicated to the COVID and its management and related issues. And we are very fortunate that Dr. Russell D'Souza has consented to deliver this lecture. We are very thankful to all the delegates to join. And this is every Saturday we are having at 4 o'clock. We have fixed the timing. So I would request our Professor Dr. Jayalal sir to give opening remarks, and then we'll request Dr. Abul to introduce you, sir. Dr. Jayalal sir. I don't know.
Good afternoon, and our beloved distinguished Secretary General of Indian Medical Association, Dr. J.S. Lele, the guest speaker, and the quite close friend, and indeed a guide and a philosopher for Indian Medical Association, a veteran leader of bioethics, Professor Dr. Russell, who is presenting right now from Australia. The moderator of this session, Wayne Dynamic, our Junior Doctor Network Chairman of National IMA, Dr. K. Abul Hassan, the distinguished leaders of various states, Dr. Subramaniam from Andhra. I'm also able to see Dr. LVK Murthy. He is also from Australia. He is joining. So, and all other leaders of Indian Medical Association and the speakers. First of all, this is a day that every week on Saturdays we are arranging this Professor Dr. KK Memorial Lectures just to highlight on how we are going to face in this COVID era and what are the work and the priorities we will be given for the mitigations of the third wave, and how will we see the post-COVID complications, how the Indian Medical Association is going to lead on that. And that's the topic which we are going to discuss. We all know and remember the good days of Dr. KK Aggarwal, who was still his last breath continuously doing on the continuing medical education program. So we have inviting very stalwarts on that field, and today we are having another very pioneering person of great contribution to the bioethics in India. And not only in India, and the globe, is Professor Andrew Russell. We used to use a name called Russellization. Bioethics, if it is today, it is circulated to the nook and corners of India, that the credit goes to Dr. Russell, and by virtue, most of us were involved in the bioethics. We have coined the term called Russellization in India, that is on bioethics, that has been done by him. If at all COVID has done something, the most formidable person who might have been affected is Dr. Russell. Otherwise, by this time, he would have visited India 3-4 times. Now, because of COVID, he is not able to come to us physically, but virtually we are in close contact. And today we are very particular that he will be able to address to us. Especially, he is going to talk to us on a very important topic, which the Indian Medical Association is concerned, because we are seeing that a lot of people are coming with the post-COVID complication. Come name any disease, and that is there in the COVID, post-COVID. And their mental issues, their bioethical issues, and a lot of problems we are facing. I'm sure Dr. Russell will be able to give us a lot of input, and that will be give us in a long way to go forward to do something actively what Indian Medical Association can do for the society. So I thank the HSG for inviting him and all the leaders who are participating in this. I'm sure that this lecture is going to help us on this day. So thank you very much, and looking forward to listen to you, Dr. Russell G.
Yeah, thank you, President sir. And it's over to Dr. Abul, our chairman, JDN, to introduce our guest speaker, Dr. Russell Crowe. Over to Abul, please speak.
Thank you, HSG sir, respected National President, and all my senior colleagues and speakers. Good afternoon to you all, and welcome all of you to this prestigious late Padmasree Dr. K.K. Aggarwal Memorial Lecture. We are all aware that the COVID pandemic has placed before us so many unprecedented tasks, either in restoring the health of the people and restoring the economy of the country. We have learned lots of lessons, both in first and second waves of COVID pandemic. And with this experience, I'm sure we will be definitely mitigate better in the third wave or any other crisis that is forecast. So aptly, today we are going to discuss the topic that is beyond COVID crisis, public health disaster planning and preparation for tomorrow. My dear friends, we have a very good faculty to discuss this topic. Dr. Russell Franco de Souza. Many of you may be knowing him because it is not only because of he is from our country, but also because he has been participating regularly in all the events organized by Indian Medical Association. My dear friends, Dr. Russell Franco de Souza is currently the Dean and Professor of International Institute of Organizational Psychological Medicine, Australia, Doncaster, UK, and Melbourne, Florida, USA. He is also the chair and head of Asia Pacific Division of UNESCO, chair in bioethics, University of Haifa, Directorate of the Asia Pacific Division and Department of Education, Melbourne, Australia. He had done his UG and PG in Madras Medical College. Later, he migrated to Australia in 1981, where also he pursued his post-graduation in psychological medicine and also bioethics. So he is an international expert in bioethics, and he had, talked in many of the bioethics events, seminars, symposia, and webinars organized by Indian Medical Association. He has received many laurels globally from many universities. And one such thing, for example, I can quote the highest academic honor, the Doctor of Science, he had received from SRM University, Chennai. So, with this introduction, on behalf of all of you, on behalf of the Indian Medical Association, it is my privilege and honor to invite Professor Dr. Russell Franco de Souza to give his talk on Beyond COVID Crisis, Public Health Disaster Planning and Preparation for Tomorrow. Over to you, Dr. Russell.
Thank you, Dr. Abdul Hassan. The very Honorable Dr. Jailal, the President of the Indian Medical Association, Dr. Jayesh Lili, the Secretary General, and all the Honorable members of the Indian Medical Association and I have to say, the Indian Medical Association has been and is one of the most important and most active units of the chair in bioethics, in fact, in Asia Pacific. Dr. K.K. Aggarwal was also the Secretary General of the IMA when the first MOU was signed between the Indian Medical Association and the UNESCO Chair in Bioethics with Marthinda Pillai, Dr. Marthinda Pillai as the president. And since then, we've had several presidents, all contributing significantly, carrying out many outstanding programs. Every president, and I have to say that I'm delighted that your current president, Dr. Jailal, was already the coordinator for the last 2 years before he became the president, and has contributed significantly, had one of the best meetings last. I always think about that, because the last time I came to India, I was at this wonderful ethics meeting that the Indian Medical Association put up in at Kanyakumari. And after that, I left a few days straight from there, and then COVID came. And from that was the last travel I did internationally, because Australia closed its borders. A week later, everyone closed. And as Dr. Jailal said, I should have been at least 5 or 6 times. And I really, that the last event in my mind, which I came for, was the IMA program in Kanyakumari, a very high quality program where we had all the state presidents becoming chairs and so forth. So it's a great honor that I have not only the IMA, but Dr. K.K. Aggarwal. I was with him every Saturday. He was part of our taking it took from the time he was the Secretary General till he died. He was involved with some way or the other with our work, and continuing with the work even as the president of the Confederation of Asia and Medical Associations of Asia and Oceania. So with that, I want to thank all of you and to giving me the honor of today's lecture that I'm going to give. I will like to share my screen, and one of the important. Right. Okay. We've had the COVID right now in Australia. We had a fairly good time in the sense we didn't have too many cases. But in the last few months, the Delta virus has come, and half of this population of this country is under lockdown. I'm speaking from Melbourne. And Melbourne, or Victoria, New South Wales, and South Australia are in lockdown. We are probably getting better, but New South Wales is affected. And so the COVID crisis goes on. But I was talking to your Honorable Secretary, Dr. Lilly, and we were looking, and I thought, we're all talking about COVID. What about tomorrow? And what do we learn from this? And so I thought I should offer to look at beyond the COVID crisis. We are on the crisis at the moment. So what is it that we think we could do? And the public health disaster planning and preparation for tomorrow. And I'm going to show you that even countries, very important countries, were deemed to be well prepared. We see that preparation when it came to the crunch wasn't really there. So I thought one of the things that one second, I'm just trying to get this. Okay, COVID-19 for all of us is teaching us a very stern lesson that economic well-being and health justice are indeed two sides of the same coin. Because, as you all know, and what we've learned in the last 1.5 years, measures to limit the spread of the disease and with that the loss of life have virtually brought economic activity to its knees in many of the richest countries in the world. Public health measures that we have used 100 years ago still has a place. Social distancing. But when we use this social distancing, we induce an economic coma. And the moment we try to bring the economic revival, again, we risk further impact on the public's health. I want to show this slide to you. This was published in Time magazine in 2017, May 4th. I want you to look at this, looking at what was predicted at the countries best prepared to deal with the pandemic. This is 2017 by the Time magazine. And what do we see here? United States ranked as the best prepared. United Kingdom, Netherlands, Australia, Canada, those, and there we go. Now that was 2017. And what you're going to see in 2020, the pandemic, the COVID pandemic really oriented a result far distance from what that study showed us on what type of, evaluation or what measures were used to deem that they were well prepared in 2017. The failures we learn from disaster planning are indeed manifest in all countries seriously affected by the COVID-19, where the infrastructure of pandemic preparedness has been lacking or in many places dismantled. Public health budgets and so forth were dismantled. Now, I'm going to turn my attention from our current public health emergency response that you and me and all of us are dealing today with the public health disaster. Moving from that way, I want to talk about public health disaster preparation and planning for tomorrow. The need for a well-informed, judicious leadership, importantly, that inspires trust in its citizens. Now that's coming from the current reality check in the last 18 months, showing you what Time magazine showed us in 17 and what the reality test showed us in the last 18 months. So I talked about tomorrow. I want to focus on tomorrow. So what about the next time? Do you think there'll be a next time? Will there be a tomorrow? My answer to that is there certainly will be a next time, and indeed a next time after that. You and me are aware that zoonotic diseases is a global sword of the so-called Damocles waiting to descend. There are thousands of virus types being exposed to naive, rapacious human contact and stand poised for an evolutionary leap into human bodies and lives. So, in order to manage pandemics and to restore the social contact that economic life demands of us, I believe a new social contract with public health must be considered. Now, what's the social contract with public health? This involves disaster preparedness and planning as an ongoing endeavor. We're dealing with it now, and we need to keep this as an ongoing endeavor, not merely a periodic pandemic activity, as we have learned the flaws of that we are facing in the last 18 months. Because if we do that, planning will affect the response. And if that's going to affect the response, then it'll impact on how tragic the ethical dilemmas of that response measures will present. So there is a need now to rethink disaster planning. Having experienced what we've seen, I think we believe that we have to rethink this disaster planning so that it becomes a civic practice. Then a disaster preparedness planning process will come to be seen as an expression of the entire community about the value of lives, the health of the members of that community. It will not be like a commercial contract between seller, the experts, and buyer, the taxpayers, and those subjects to the plan's provisions. Rather more as a social contract, an agreement to be entered into by all that establishes commitments of responsibility for each of the citizens of the community. So a new social contract with public health then requires a new form of civic thinking, a new ethics of public health citizenship. Let's look at institutional and behavior change. In this situation, then, there is a need to bring about institutional and behavioral change that emergency preparedness and response requires. It is then essential to see health as genuinely public, as something that involves all, as a common good, not as a commodity we pay for and consume. The quality of the population's collective and individual health depends on an intricate web of cooperation and indeed interdependence. This will require focused, organized, ongoing settings for deliberation about the citizens' common lives together. Now, civic practice and civic engagement, where do this stand? From the current evidence, it seems a lack of civic practice and engagement, civic engagement, are created more by cultural and political attitudes to exclusion rather than equalities of wealth. That's what we begin to see the evidence from around the world. The tragedy that COVID-19 pandemic has caused will only deepen further if there is a failure to find the leadership and the political will to revitalize the democracies, indeed by enhancing opportunities for civic practice and civic engagement, but importantly, that is ethically informed. A new social contract, thus, may be required with our democracy itself, as well as the new civic conscience for public health. Now, disaster preparedness planning. Disaster preparedness planning offers these opportunities, what we're talking about, because it grows out of social vision. It's backed by epidemiological research. It sees memberships in large communities as the very root of health and well-being of that community. It grows out of political and moral vision. This disaster preparedness and planning should be backed up by democratic experience at the local level. When we talk of experience at the local level, this is where it sees in the activity of democratic participation and deliberation a process of civic learning. And this civic learning has positive effects on citizens as human beings, as people. Thus, it enlarges the citizens' imaginative capacity for a sense of justice, empathy, solidarity, and indeed openness to cultural and personal diversity. When you come to emergency planning from civic practice, emergency planning must focus not only on the steps to be taken in the immediate aftermath of a catastrophe, but we must also think on upstream assessment and preventive measures, and then downstream recovery and mitigation. So we see emergency planning is vital and indeed a reconciliator, a healer, and a comforter in the aftermath. There is a requirement of building codes and their enforcement in times of storms, floods, earthquakes, and so forth. The proper maintenance, now we're talking about emergency planning, the proper maintenance of, in many countries, aging infrastructure of our cities. When we see in some places lead poisoning from drinking water shows up. These and similar situations are integral components of preparedness planning, for they too protect lives and they too defend health. So when we come to the environmental part, we realize the loss of biodiversity and the ecosystemic degradation that we see around the world should also come within the purview of this emergency planning, because they affect flood control, groundwater contamination, risk of exposure to zoonotic viruses like the SARS-CoV-2, and indeed the emergence of antimicrobial resistant organisms that we are beginning to see or beginning to experience. And there's, of course, emergency planning and social activity. When we look at a civic perspective, from a civic perspective, when we look at emergency planning, it sets in motion a whole social complex. Think about it in this planning perspective. The social aspect, we're having discussions, large meetings, small meetings, network among officials, professionals, local organizing, and educational activity. We see the creation of a new communication channels and the recruitment of specialized individuals, or at times retraining existing personnel. All this is what we refer to as the social complex in emergency planning, the social activity. We bring in so much of social activity. So from the civic perspective, emergency planning sets in motion this whole social activity. Now, emergency planning cannot wait. There will always be powerful opponents to aspirational civic life and civic learning in any democracy. There will be structural conditions of injustice, inequality that may block these values. But emergency planning cannot wait until all these pre-existing barriers move to full exclusion, participation, getting everyone in the community involved. or indeed until broader social problems like poverty are solved, because we know that will be a long term and it cannot, emergency planning cannot wait, it needs to be attended to. So disaster planning must cope with the society as it is, not as it should or could be. Civic practice of disaster planning must converge with other activities in the community, particularly related to social reform, civic renewal, and resilience building, or what we call hardiness. Having said all these here, talking about tomorrow, what I've looked at, disaster planning and preparedness, and the place of this civic engagement, I'd like to say that civically inspired emergency planning can contribute not only to specific health and safety goals, but also to the task of reinforcing the citizens' very important social and democratic values. That's evidence we have. Successful emergency planning also can tap into pre-existing fund of civic responsibility, and with that, concern for others in need, an altruistic component of the human. Emergency planning can and should be an occasion to foster these outlooks. It's a great opportunity to foster these outlooks and impulses, but remembering fear and self-interest will no doubt be strongly evidenced during any public health emergency. So, we'll conclude that public health leadership can aid communities, indeed moving beyond these motivations, ultimately to a sense of common purpose, common good, and with solidarity and cooperation. I'd end with that, and I say thank you very much for giving me this opportunity and listening to me.
Thank you very much, Professor Dr. Russell D. Souza. Your talk was excellent. You have dealt it very, very deeply. And particularly, the one thing I was really inspired in your speech is repeatedly you stress the importance of the commitment of the people. And finally, you have concluded that it is a civically inspiring emergency planning.
Yes.
That is very, very important. I think there is a take-home message. Unless the public people participate in any mitigation activities, it won't be that successful. Professor Dr. Russell, there will be some questions. Now another wave is forecast, and our country is planning to taking lots of measures. Indian Medical Association is also cooperating with the government in the form of surveillance and also treatment, healthcare delivery to COVID victims, and also particularly vaccination. I hope there will be questions, but let me start with a few points that we are worried about the involvement or suffering of childhood population in the third wave. There are lots of discussion, many scientific fora, that who will be affected more in the third wave if it always comes, the children or everybody. And secondly, there is another kind of a discussion about getting a booster dose of vaccine or third dose of vaccine for Covishield, Covaxin. I think we will start the discussion with the points or throwing lights on these two particular things about COVID, which are facing us today, so that we will have some more, take up some more questions from the thing. So will you please throw light on involvement or, it's a childhood population, how far they will be affected, the third one, the need for a third dose.
Thank you for that, Dr. Abdul Hassan. You see, this whole, we are learning things that you and me knew or thought, or the world thought we knew in April or March last year has changed completely, right? We thought about children not being affected, but we're learning that this isn't true. And today, our thinking, although down the track it might be different, but certainly from what we know, certainly from United Kingdom and others, and even in Australia, we are now having I don't know if it's second or third or whatever, but the Delta has come in here. But what we've learned today or yesterday, they have approved the Pfizer vaccine for 12-year-old to 14 in Australia. It was already in USA. Now, there is this question here, urgent, what we learn now that
Russell ji, only just minute, we have Dr. Sushil Gupta has just joined.
yes.
Dr. Sushil Gupta, he just there, he just joined, I saw.
Where is our Dr. Sushil Gupta?
Okay, he left again. We'll get him.
Yeah, he was joined. Yes, he's your Delhi.
Yes, back. Dr. Sushil ji.
Yes, Dr.
Sushil
Sushil.
Gupta, our Honorable Member of Parliament from Delhi. We welcome you. It is nice since Russell is going to talk to us. I thought Sushil Gupta ji will be happy to be with us.
Yes, Sushil Gupta, Dr. Sushil Gupta is also very actively involved in our program. He heads the school program. And I think, Dr. Abdul, what you're asking has a different effect on Dr. Sushil Gupta's, what he's doing in school program. Because what we found in Australia, it's clearly now found that the children, while they do not necessarily have the symptoms of illness, they are the ones with who are carrying the infection, and so the teachers and others have the whole education department and so forth have come up now wanting that in the interest of the teachers and so forth that the children need to be vaccinated or immunized, and that was one of the pushing reasons why the age 12 to 14 has been approved after, of course, some amount of data that has been available from other countries and so forth. So that is an important issue that we are seeing. And the second thing is that we actually are beginning to see there is good evidence from United Kingdom that the change has taken place, and the more seriously ill are the younger folks getting into hospital. And some of them think that the older people might have been already immunized, but even in New South Wales, Sydney, I see that more than half the intensive care are now people 30 years and below. So certainly this is a trajectory that we are learning, that younger people, as the mutations come and as the change is taking place, it seems to be affecting the younger population. Now, given what we learn from what we are seeing, we also are seeing that our immunization programs, although they are in some countries are not as advanced as United Kingdom and others have been able to get nearly 70% of their population. Australia is lagging with a smaller number. But what we also are learning, and exactly what you brought up, that the efficacy is also dropping as these. I just read today that the mRNA Pfizer vaccine, which was showing 80%, 80, 90%, what do you call it, efficacy, has dropped down. And today I read that Israel has got probably the most evidence because of the exclusive use of this, and a large percentage of the population being immunized, that we see that the younger folk, the mRNA which was being given for young, it is not below 50s, it's not against the Delta, it is only showing 40 to 50, somewhere in that range, efficacy. So they have already applied for the bringing in the third, the booster doses and so forth. So as it stands, we are in this state that we keep moving, we keep learning, and I think what isn't, we certainly are, all countries have already started placing orders for the booster vaccines and so forth. So the last word is not yet come out, but I think that's the way the next pandemic, which you're expecting, the next wave or so, I think the one needs to have all what we talked of, disaster preparedness. But I think the younger folk would be more likely to be more at risk. And of course, the only way we know that we can solve this is by immunization. To even if it only got 50 or 60 or whatever, that at least guarantees that we might not get the hospital or at least the respiratory problem. Although now we are learning about long COVID, and so even those who had asymptomatic illness, now I see a large number of asymptomatic, right up to 80% are having long COVID symptoms with brain fog and chronic fatigue and so forth. So these are certainly the important aspects that we need to think about. And for this very reason, that our planning for tomorrow, disaster prepared and planning, has to be, we should have learned this, because I showed you in 17, our study said United States had the best preparedness. And you and me know that it wasn't so, in judging from what happened.
Very good, sir. Sir, in the same context, I would like to ask you, we know that there are countries which have literally escaped from this pandemic, except for very few cases. In your opinion, which country had the highest preparation, public health preparation, sir?
That's why I showed you what was there in 17, but in reality check in 20, I don't know if anyone was prepared that well enough. Even China, with the authoritarian rule and so forth, had its own issues. I'm not sure who was that well prepared. To an extent, New Zealand, Australia, and probably they said
Taiwan also, I think.
Taiwan was, but they had a second. They were the first, and we do have a very part of our UNESCO program we had. But unfortunately, Taiwan was so good that they declared this in December of 19. They already had declared it as a pandemic, and they shut down. They started, but unfortunately, no one listened. The WHO didn't listen to what they were saying. So they ended up with virtually no deaths at all. But they had a second that came later, and that affected them. But yes, Taiwan, New Zealand, these are the countries. Australia was doing well, but they had a problem and had a few hundred deaths due to that quarantine failure. And so that was someone else. New Zealand Taiwan, and they said all the female presidents.
Prime ministers.
Which was the other one? Denmark, is it? No, some country which had a female.
Oh.
I know it was Taiwan, New Zealand, and there was one more with the female leader. But they are smaller populations. Taiwan has got the same population as Australia, and New Zealand, of course, has only got 5 million people. You see.
I invite questions from our participants. Whoever wants to ask question, please raise your hand. Dr. Russell will be happy to take up a few more questions, I believe.
Well, I have a question when Russell is going to come to India.
Dr. Jailal, I am hoping and wishing that when this will open, we in Australia, we have this problem that we are not, it's closed. And so if I want to come, I have to get, I guess I could, we have to get permission if it's a, work related and so forth. But we also have another problem that this country, we have about, I think in India, maybe 8,000 or 9,000 Australians waiting to come back. They're not being, because of the problem, you have to go into quarantine. They are rationed, so you have to wait for your turn to come back. But I certainly I'm hoping that, by the end of the year, that things will change and improve. And we should be there to get back to all the wonderful things that we were doing. Thank you for that, Dale. I certainly would like to be there.
What is the status of this real post-COVID clinical disorders like respiratory lung disease, and still people are suffering with that? Long COVID.
Long COVID, yes. Yes, that is the issue that we're concerned about now, and the studies are showing that it seems to be predominantly those who were asymptomatic, and that's a worry also for the young children and others who might be asymptomatic carriers and so forth. So a lot of things we are going to learn as we go in this pandemic. Yes. And I hope that I will be there with all of you in the not distant future. And also we all will be coming out. I don't think you're also going anywhere. Is that right? Jailal, are you traveling out? Are people traveling much?
We have 5 Australia in India. So we are traveling with one Australia to another Australia.
Yes, we know this is I haven't, Dr. Jailal, after I came to your meeting, in 2019, I only spent out of 12 months, only less than 2 months in Australia. I was traveling and attending, all over. And since I came to your meeting, I came back and I have not moved out from here yet. That was the last very nice, pleasant memories of a wonderful meeting we had. Yeah.
Dr. Russell, there is one question in chat box.
Yes.
I just directed to you. What is the experience of Microsis in Australia, sir?
Well, we were discussing this. We have a meeting of. I attend that on Saturdays on the CMAO meeting, which Dr. K.K. Aggarwal started, and it went on. Today was the 67th or 68th or whatever. But this question was discussed, and many theories or thoughts were given why this was not seen in many other countries. Certainly, Australia has not had. We didn't see that, and they were all looking at this mucormycosis, and some thought today's talk. We had someone. They were talking about the possibility of soil and temperature and all that, but I'm not sure whether this was a predominant issue in any other part of the world beyond India. But we certainly never had, people were looking about it, we're talking about it, but we have had some discussions at this meeting, looking at why this happened or how, but I think most of the experts who were talking today were talking about something to do with soil and about, the spores, these spores being much more prevalent. But then again, I don't know if it happened in Pakistan and Bangladesh, which is very similar yeah.
They have
But-
also reported, Pakistan,
Okay.
Bangladesh also they reported Microsis cases.
So that was
Uh,
probably why they said
yeah.
it's soil temperature and so forth. They said that's what they said. But we didn't have.
One more
this-
the associated condition is diabetes in all these patients.
Yes, they spoke about uncontrolled diabetes and the use of steroids.
Yes.
The excessive use of steroids and uncontrolled diabetes. But then again, I'm sure in other parts of the world there must be uncontrolled diabetes, and I'm not sure whether only in India they used the steroids excessively or so. I'm not sure, but they did talk about the excessive use of steroids and uncontrolled diabetes being some of the other factors that could have brought this mucormycosis. Yes.
Yeah, you can please.
I think Dr. Abul will
Yeah, yes, sir.
close the meeting.
Yes, sir.
Thank you, Dr.
Thank you. It was a great pleasure to be with all of you.
Yeah, sure.
Because my heart is still with all of you there. I'm here, but
I know. That's why our president requested for this particular topic, and you are kind enough to deliver the very important memorial lecture. Dr. Abul, thank you for
Thank you.
moderating this session, and we really thank all the delegates for joining and participating. Thank you so much for all.
Thank you, sir.
Yeah. Okay.
Thank you for the opportunity,
Thank you.
President.
See you next
That's
Saturday.
it.